is Jennifer Bellon, and I'm the Director of Breast Radiation Oncology at Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston, Massachusetts, and an Associate Professor of Radiation Oncology at Harvard Medical School. So I think one of the most important improvements in radiation oncology in the last 10 years is that it's to make it less burdensome to patients. And one of the major advancements is the use of hypofractionation. And that's when radiation is condensed over a shorter period of time, rather having the patient come in daily for a period of up to 6 weeks. So we have strong data now from Canada and from the UK showing that short course of radiation in the breast conservation setting is equally as effective as longer courses of radiation, but has improved cosmetic outcome and is more easily tolerated by the patient. So I think in women who undergo breast conservation, that's now our standard of care for almost all women. We still have some hesitation about women who are very young, not because we have any information that their outcome is inferior with short courses of radiation, but just because we don't have as long follow-up as we do with conventional radiation. We certainly expect many of those women to be long-term survivors. We have some uncertainty about women who have undergone mastectomy. We don't have great data about long-term rates of lymphedema and impact on the reconstruction, particularly the cosmetic result with hypofractionation. So at least in our practice, that remains a treatment we do only on a study, on a part of a protocol. And there is now an ongoing alliance study, multi-center, large randomized trial comparing conventional versus standard hypofractionation in the post-mastectomy setting. And we also have a trial that's led by Dr. Julia Wong and Rina Punglia, led from Boston, also a multi-institutional study looking at hypofractionation in the post-mastectomy setting. I think another main area for improvement in breast conservation patients is knowing when we can do less. And I think that is something that we've only recently begun to appreciate, that there's a tremendous biologic diversity of patients, that all tumors are not the same. Large series have shown us that women with luminal A patients have low rates of local recurrence when they do get radiation. And so this has naturally led us to ask the question whether women with biologically favorable tumors can omit radiation safely in the breast conservation setting. So there's a large prospective trial from the University of Michigan identifying women with low or intermediate grade tumors and a low oncotype score, and prospectively following those women with hormonal therapy alone. And we have an ongoing multi-center phase 2 prospective no radiation trial in women with luminal A disease by PAM50. There's also a trial ongoing in Canada identifying lower risk women with a low Ki-67 score. But all these studies are trying to ask the same question: can we safely do less in this patient population that we've hopefully identified as being biologically low risk? So I think both of these areas, shorter courses of radiation and omitting radiation in appropriate patients, are going to be huge advances for our patients.